I am Dr. Amy Loden Tiffany, and we are broadcasting from St. Louis. I have Dr. Caissa Troutman here with me. I'm so excited for you to hear what she has to share with us today. She has many, many accolades, and so rather than me trying to stumble over them, I'm going to let her actually introduce herself and tell you a little bit, and then we're going to jump in and get started.
Awesome. Well, thank you so much for inviting me over,
Yes.
Dr. Loden
Yep.
Tiffany. Yeah.
Yep. Yep.
So I'm Dr. Caissa Troutman. I am the physician founder of my medical practice in Pennsylvania called Midlife Remedy. And I help women lose weight, balance hormones, and feel like themselves again.
I love that. And I'm going to brag on you for a minute, if I may.
Yeah.
What many people don't realize is how hard it is to get board certified in one specialty. And I worked really hard to get board certified in 3 specialties, but you've done even more than that. You're quadruple board certified.
Yes.
Amazing.
Yes.
So, can you tell us a little bit about that process? Because there's obviously a lot of reasons you did what you did. What was your story?
Absolutely, yes. So yes, I am quadruple board certified in family medicine, which is where I've trained for 20 plus years. I'm obesity medicine, which I always describe it as more just understanding the science of weight, and culinary medicine. And the way I describe it is again just translating theoretical into practical eating, nutritional, lifestyle strategies. And I'm also a Menopause Society board certified. So again, understanding this midlife transition and how it really is not cookie cutter and
No, not at
very
all.
complex. And the way I've always described it is honestly, it's my me search. I am a patient. I've struggled with weight my entire life, as early as childhood. Um, and I'm a woman in perimenopause that struggled with my own symptoms, not realizing it was actually part of my own perimenopause story. And that's why it's like turning my pain into passion and my personal story into how I do my professional kind of inclinations at this point.
That's
And
beautiful.
I love it.
Yes. The first time I met you, you just had this huge smile on your face, and I can tell how much joy radiates from you, and
Oh,
you're passionate about what you do.
appreciate
So
that.
thank you for doing this.
Yeah.
Um, if you think about kind of midlife women, we'll start there. There's a lot of things that we know in medicine, and there's a lot we don't know.
Yes.
As you think about the patients that you're serving, are there any themes that come up for you? Things that are really a disconnect between what we think in medicine and yet what we experience and our patient had, or what our patients are telling us they experience? Anything come up for you in those
Oh,
areas?
so many. And I think the first one is, and I hate to use this word sometimes, is being gaslighted. Like the symptoms that we feel. And I could maybe kind of put this in the lens of before I knew what was going on and then after I knew what was going on
Yes.
lens. Because, at the heart of it, all clinicians, providers, we all want to serve our patients, right?
Yes.
But we have a finite amount of knowledge, and when we don't have that knowledge, we do the best we can. So for me, even in the before I understood what was going on, I did kind of like, um, I would say, not serving my patients in the best interest. And but from this lens of how I see it now, a lot of the symptoms that we normally um, attribute to aging or just getting older or just stress, which are very problematic symptoms, right? Fatigue and joint pain and so many other symptoms of perimenopause, which we can deep dive into later, is part of this biological transition. And that's kind of for me, once I kind of learned that, like, oh my God, it's like it's real. it's
Yes.
not it's not in our head.
No.
It's not in our head. And I've heard so many of my patients have been told that. Have been told they're too young, have been told, so many kind of really hurtful words, or just not being validated, not being listened to. And again, we're not saying everything is perimenopause and menopause, right? We know
Right.
it's not all that, but what if, right? That's always like the way I kind of look at it too.
Yeah.
Basically, we just need time to listen to our patients and validate.
Yes. Yes. Wow, there's so many things we could go onto there. So we could talk about the time that the system doesn't give, right? The
Yes.
validation needs that maybe not all healthcare providers are trained to express. The two things that came up for me first, though, were this idea when I was in med school and residency before I did my menopause certification, we were really taught to offer these women SSRIs,
Yep.
right? Hormones never came up.
Yep.
And we can maybe spin in hormones later, but for just a second, it was really this SSRI and this idea that it is all in your head and you just need a pill to make it go away. And then maybe the last 10 years or so, I've heard a lot more noise about something I actually don't provide because I think there's some real harms and risks related to it, which is testosterone pellets. So both of those come up for me as listening to you talk, and I'm curious, where would you land on either of those, or what would you say?
So yeah, I think when it comes to like issues in general, the way I've kind of divided it, even like this is how I also apply it to like normal everyday struggle, whether it's weight or menopause, perimenopause, is it's a knowledge gap. Like we
Hmm.
don't know what we don't know, right?
Right,
It's a
right.
skills gap. Like we may know what it is, but we don't know how to apply it. And number three,
Hmm.
it's a mindset gap, right?
Yes.
Like so if we apply those three kind of gaps and apply
Hmm.
it to midlife, for example,
Hmm.
like the knowledge is there. We just need time to like learn it. And we know
Yes.
in the current healthcare system, where you see 30 patients a day, like
Right.
you're tapped out at the end of the day. There's
Right.
zero energy
Yes.
for learning, right?
Hmm.
Um, and maybe skills. Maybe they know the knowledge, but they either don't have the resources to apply
Hmm.
it or
Yes.
whatever. And then mindset, it's the
Hmm.
information is there, right?
Yes. Yes.
But I know, but sometimes it is about um, being aware as a clinician that maybe I didn't know everything.
Hmm.
And
Hmm.
sometimes that's hard, I think,
Yeah.
for someone who studied majority of their adult life
Right.
to say I didn't know everything. I don't know.
Yeah.
That's kind of how
Yeah.
I look at it in terms
Hmm.
of like this whole kind of issue. So in terms of the issue the second question that you had, testosterone pellets, right?
Hmm. Yep.
Yeah. So how I always approach that, if I have somebody either message me on social media or kind of ask me about it, like
Hmm.
kind of off the cuff, is first of all I kind of ask like, why do you want it,
Yes.
right? Because at the root of that is, again, people want to just feel better,
Yes.
right?
Yes.
So when we kind of like when I ask them, so why do you want it, and then they maybe mention some symptoms, and um, I would kind of like approach it like, I see where you're coming from, and I would love to help you. Did you know that there are options that have less risk? So
Hmm.
I do not prescribe testosterone pills, but I prescribe FDA approved testosterone for men that I microdose for women, or
Hmm.
as like Ishwish, which is the sexual health medicine. Kind of that's kind of our guidance with that. Is it is 110. So the way I always like we can replace the hormones in a much safer way, where we only aim for what we call physiologic levels.
Hmm.
So basically, giving our body back what it has seen before, and not aiming for what we call super therapeutic or just above what we normally kind of see.
Yes. And that's such an interesting point too. And the reason I wanted to get into it is this whole idea of everyone sees this information, whether it's Dr. Google, Dr. Chat GPT, all the
Mm.
social, right? Like, so people know it's out there, and then they come to their doctor, and their doctor just says, "No, we don't do that."
Mm.
And I think there's this big disconnect of, well, why? Because the information's there. So when you see that disconnect, is there anything that you would do differently if you had known this like 20 years ago? How would you have approached these situations if you'd had better training?
Um, well, I think at the root of that again is like at the root of it is physicians, clinicians don't want to hurt patients, right? So I think that's why they say, no, I don't do that, because I think you'd have some a sense of responsibility if you prescribe something to a person, to a patient. You kind of need to know what it's about. How, is it going to be safe? You want to probably know what to monitor, right? And the reality is, a lot of doctors don't know that,
Yeah.
right? And if And if now if for us that are trained, we know that, so it's not an issue for us. And again, the way I've set up my practice is I spend time with my patients, so I really understand what their issue is that really what they need, and all that stuff. So in if I think for 20 years ago, man, I was like an exhausted
Right.
mom who had zero
Yes.
time. I mean,
Yes.
it is, I feel, and that's kind of why I left, and opened my own practice, because I think it was a decision between two different hard decisions, right? If I choose to stay in that setting, the hard part was, oh, how do I survive the day? How do I take care of a
Yes.
patient? And
Right.
this pathway is also hard, in its own way.
In a
So
different way. Yeah.
yeah, I think I was just so tired 20 years ago.
Right.
Like, I had no time for
100%.
self-care. I had no
Yes.
time to recognize all the like mini traumas I've experienced, through
Mhm.
being a doctor, being
Yeah.
a parent. It's yeah. I don't
Right.
I don't know how I would have. So anyway, I probably would have answered it the same way 20 years ago. Like, I don't
Right.
know.
Yeah.
I don't know. I won't. Yeah.
I love that you say it that way because I think all of us have this tendency in healthcare and specific. I think we have this tendency to beat ourselves up or regret not having done something differently for lack of knowledge. But the whole point is you didn't know because you didn't know. And I don't think that most people understand how little training you get in the different
Mhm.
areas of medicine beyond what you're certified in.
Mhm.
So there's this idea that medical school schools are for everything, and so therefore you're at least know something about everything, and we would hope that's basically true. But there's a reason that we go and do focus training in our chosen specialties, and then with menopause specifically, there's an actual lot more to it that you have to do. It's not as easy as saying I'm a GYN or I'm an internist or a family or whatever, and this is what we do. So I I have a lot of compassion and grace for the people who are trying to work in that system
Oh my
because it
God.
is ridiculous. 30 patients a day easily for primary
Plus
care.
inboxes.
Correct.
I'm like,
Let's talk about that for a
oh my
second.
God. I'm
Yes.
having like
So
PTSD remembering those times.
totally. And we don't have to go there if you don't want to. I guess I was still working in that realm when the Mayo study came out that talked about how for every hour a doctor spends in clinical care, so talking to patients, caring for patients, they have 2 hours of administrative work they have to
Mm,
do. And how that if primary care doctors did everything they were supposed to do, they would be working more than 26 hours a day every day.
right. Yeah.
And so I don't think that that is understood well. Um, by those who don't work in the system. Just like I don't know how it works in other systems, right?
Right.
And so you chose to leave. I chose to leave. We've created a better reality for ourselves. How do you think your level of care, besides just the time you spend, what are you doing different now that you can spend more time? How is your care improved, or what are you doing that you wish you could have been doing? Anything on that topic?
Yeah. And I think I would start with how it affected me. And then I'm going to translate out how my personal changes have impacted my own patients.
Love that.
Well, how it's affected me is I'm able to spend time in self-care. And self-care to me is not massages or anything like that. Obviously that could be part of it,
Right.
but for me it is time to decompress, time to just be mindful of my own humanity, time to be like uh not be in that hustle mentality of grind again. Like I didn't know it was hard until I left it. I mean, yeah.
Yes.
So yeah, time to be with my family, time to be with my kids. I mean, as
Yeah.
you probably know this too, like how many missed uh holidays, so many, how many missed like events of my kids life did I,
Right.
so many missed opportunities. And then we can talk
Yes.
about that in a different topic, like the mom guilt of miss as a working mom. And then so when you heal the human in the doctor, I think it just you get to be a little bit whole,
Yes.
and you get to be more patient, you get to be more and when you're coming from that kind of safe space, then it's like, oh my God, I want to learn more. And I think
Yes.
honestly, that's why I think for me, that's how I became quadruple board certified. You know what I mean? Like,
Right.
I had the energy to like deep dive into it. I had
Yes.
the inter like from survival. And I know that that gets thrown a lot, that word, but I was totally surviving for 20
Mhm.
something years. And
Yeah,
then to just a little bit of like breathing room to actually like, oh, I'm a human. I can
right.
actually, so yeah, so that is what led me to being quadruple board certified. That is what led
Mhm.
me to be prioritize my health, and
Yes.
and then learn more than just here's a prescription. Learn about, okay,
Mhm.
how do I eat, how do I work out, how do I address stress, how do I address sleep. So because I gathered that knowledge, the impact to my patients is tremendous. I
Yes.
mean, I coach my patients, like the
Mhm.
trauma, the really the self empowerment coaching, which is huge.
Yes.
um they get to my knowledge, right? I get to give it my knowledge in a way that they can understand. And again, just being in my, when I'm whole and complete,
Mhm.
and I can show, it's much easier to give
Yes. Yes.
of
Because
yourself.
you're giving from abundance and not scarcity.
Yes, yes. Yeah, so
Yeah.
that's where the people that still are like seeing 30 patients a day, I think they're just like, right, like so much closed energy.
Right.
So how can,
Yes.
and then yeah, so for
Yes.
when we're in where we're at, yeah, so much more to give
Mhm.
and willing to give.
Right. Yes.
Yeah.
I love that. Some of our listeners may not have heard yet. There was a pretty big shakeup announcement from the FDA in the last couple of weeks about the black box warning in estrogen. Has that trickled into your practice at all? Or are you hearing much noise about that yet?
Yes, I mean, it hasn't really affected how I practice, to be honest, because that is how I
Right.
tell my patients
Yeah.
about it.
Same. Right.
I would say it has, certainly gone the social media route, and a lot more patients. I think it's a good thing, right? Because it does kind of um, maybe take the fear out of some patients who were maybe hesitant before,
Mhm.
to even think about it.
Yes.
Yeah, but
Yes.
at the end of the day, it really does. I mean, it has to be, and I know you do this too, like a
Yes.
nuanced,
Right.
personalized risk benefit discussion for a
100%.
woman. Yeah,
Yes.
yeah.
Yes. Well said. And the reason I pick on it a little bit is I get the sense that some people in my practice are like, am I missing out on something? Right.
Mm.
But to your point, and this is where I wonder, can I do a better job at helping promote trust to my patients? Is I look at the guidelines, I look at the science, but I look at my patient.
Mm-hmm.
And I ask my patient, what's going on with you? What's in your body right now? What is your body telling us? And viewing it from that perspective. And so as when I wear my patient hat and I think about how rushed the visits are and how I'm treated, even though these people usually know I'm a physician, it bothers me tremendously because I feel like that's not necessarily, that's probably how everyone's being treated, right? And if everyone's receiving that kind of care, like, what are we doing?
Mm-hmm.
So I think the way you're addressing it makes a ton of sense, and I applaud you for doing it. I think it's really interesting too that you went a little bit different stream down this culinary medicine pathway.
Oh yeah.
Do you want to say anything about that? I mean, I think most people would applaud the idea that we want to eat food and we want to be as clean as possible, but what does that actually mean, especially on a budget?
Yeah, yes, definitely. So I did the pursued the culinary medicine because I wanted more nutrition training. I wanted to be able to um, help my patients know what to eat. So because we did have, well, I think very minimal
Minimal.
nutrition training.
Yes, minimal is a great word.
Um, so, and I was already in an obesity medicine practice,
Mhm.
and we didn't have, again, just like anything, RDs were hard to find. We didn't have
Mhm.
that support. So uh, I wanted to give my patients science backed information. So that's why I pursued that. Um, how do, so basically it's helpful because I get to break it down. So like, for example, one of the more common kind of recommendations is make sure you eat your protein.
Right.
Like, a lot of patients kind of get stuck on that and think of just, okay, protein shakes and protein bars, right?
Right.
Because that's what you see on social. But
Yes.
we can totally get the 60 to 100 grams of protein from real food, and I just
Yes.
kind of break it down. Okay, if it's animal protein, use the palm option, the 3 ounces.
Mhm.
If it's plant protein like beans, use the hand hand portion sizes. So even as simple as that, I can tell you, like my patients, they even like, they're like, oh my God, I remember that. I look at my palm and this is
Mhm.
had 20 grams of protein. So those little things is again how you apply it to real life so that it can be useful.
Yes.
Yeah, yeah,
I love that. And I'm really curious if you could teach us, because I don't think most people know the hand technique. Can you teach us, like if we
absolutely.
were your patient, how would you teach us to
Sure.
use our hand?
Yeah. 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 Of course. So first of all, so we're talking about protein, right? So we always say for animal protein, uh, 20 grams is, sorry, for animal protein, 3 ounces is equivalent to 20 grams. So I don't normally have my patients weigh their food because for some people
That's a
that's a
lot.
little PTSD, a little bit, triggering, especially in patients that have struggled with weight their entire life and have been told
Yes.
to diet as early as 11 years old.
Oh my gosh.
So to me, so the hand portions are a good way of doing it. So anywho, so what one palm, so just the palm without the fingers. That's, and
Mhm.
you need to look at not just the the size, but also like the what do you call this? The lateral portion. So
Mhm.
width and height, I guess,
Okay.
it is roughly um 3 ounces, which is 20 grams. So the other way I showed is like a deck of cards, right?
Okay.
So that piece of chicken, that piece of fish, that piece of beef is roughly 20 grams. So if we want them to have a minimum of 60 grams, hey, have the deck of cards for breakfast, lunch, and dinner. I mean, that's like a
Yes.
nobody eats
Right.
chicken for breakfast, but just a
Yeah.
thought, right? And then if you want to have visualize like a cup, so usually I always say like a cup of fruits.
Mhm.
So that would be like close your fist. That's roughly a cup.
Mhm.
Now that's usually for women's hands. Men's hands are a little bigger, so I always use the woman hand
Mhm.
option visual.
Yes.
And if you have like a cup, I'm sorry, your palm, if you cup it, kind of like you're
Mhm.
filling it up, that's
Yes.
roughly half a cup. So I always reference it for like the beans. So half a cup of
Mhm.
beans is roughly 8 grams of protein. Again, they're not going to be all 8 grams, right? So
Right.
it's just like a guesstimate.
Roughly. Yes.
And then, so nuts would be another one that's filled with protein. So your index finger from the knuckle to the tip, that's roughly 1 ounce.
Mhm.
So that's 1 ounce of nuts. It's around
Mhm.
5 grams. So yeah.
Love that. Yes. And I think there's times when people know little bits of pieces, but thanks for showing that because I don't know that that's consistently easy, accessible information in everyone's communal memory
Yeah.
of what
Yep.
to do.
Hmm.
The other thing I run into when I'm talking about with nutrition on people, I didn't do culinary medicine, I did lifestyle medicine, but there's a substantial amount that's nutrition, right? And
Great overlap. I mean, yeah.
exactly, exactly. One of the things I liked about it was this idea of healing yourself naturally where you could in your
Hmm.
habits. But when it came to nutrition specifically, I got the sense that, and I think this is real for a lot of people, is fresh fruit and vegetables can be very expensive, especially in food deserts, right? Places where there's not easy access to them.
Yes.
And it became a frequent topic between our colleagues. Like, it's not enough to say fruits and vegetables, right? As we're heading into winter, and there's now we have tariffs and there's more pricing structures that are affecting cost. When is it okay to switch to canned foods or frozen fruits and vegetables? And that's a question I get a lot in my practice. Do you run into that, or what would you say to someone who?
Yeah, I use frozen stuff all the time
Yeah,
personally,
yeah.
and that's actually what I tell my patients.
Hmm.
Go get some frozen spinach and you use it in your smoothies or put it in soups or
Yes,
all that. I personally use the frozen fruits myself,
yes,
like as a
right.
snack actually, and in the smoothies. Um, yeah. So, and then for the canned, um, I also do that. I mean, the one thing, if they have hypertension, we always recommend to kind of rinse it just to
Hmm.
take out the sodium in it, lessen the sodium content as much as possible.
Hmm.
Yeah, I'm a big fan of frozen stuff because, especially in this day and age, I don't know about you, but in our house, let's say we buy a fruit and then my kids go in spurts, like they eat
Yes.
it and then they stop.
Yes.
So we
It's
buy more
maddening.
and then they eat it and then we buy it and nobody eats it.
And they
So it's
brought,
like goes to waste. So
yes.
I've actually gone, if it's like, I've learned my lesson with my own children that okay, nobody's eating it. I'm gonna like chop it up and freeze
Uh-huh.
it. So
Love
that's what
that.
I do too. Like even with like frozen veggies, if it's
Yes.
like bell pepper that's gonna go not when it's bad, but like
Right.
nobody's eating it. I chop
Yes.
it up and I put it in the freezer, and then I use it for omelets or any. Yep. So
Yeah,
soups.
I think that's a really good point because most things that are frozen are flash frozen in their
Hmm.
peak
Yes.
health, right?
Yep. So the
And if
nutrition is
we
there. Yeah.
correct,
Hmm.
and the canned, I agree with you. I tell people, I don't care what it if it comes in a can or a plastic container, rinse it. I don't care what it is, just rinse it. Um, I don't have a problem with people using those, especially this time of year when people are more budget aware because things have gone up so much. It's not the peak
Yes.
growing season. So that's really helpful. I want to switch a little bit and go back to the midlife women part. And as I think about nutrition, I find a substantial number of our patients in the 35 to 55 age range, female patients, they'll tell me, I'm not doing anything different, but now I've got this belly.
Mm.
And it almost feels like this apron or this tire around my lap, and I can't get rid of it. And I've never eaten, differently. I haven't exercised differently. My sleep's good, and yet I still have this. They don't want to do hormones for a specific reason or other. They don't want medicine. So, what would you tell that person? How do you help shepherd them through that conversation and what they can do holistically?
Absolutely. So the first thing I always say is, again, I validate the patient's experience because it is true. And we know that, right? So there's
Yes.
this the Swan study with women across the nations where they looked at perimenopausal women through the years and up to menopause, and saw that there was a decrease in muscle mass and
Hmm.
there was an increase in fat mass. So simply by, so we know that to be true, but a lot of people don't know that, right? So I always
Yes.
say, yeah, I totally hear you. You're absolutely right. Let me show you the study that validates what you're saying. Okay.
Hmm.
So now we're on the same team, right? Because I
Yes.
believe her. And I really do. This is not like
Right.
faking it. This is really
Right.
true. And again, and again, multiple studies have shown that the fat doesn't distribute everywhere. It doesn't go where I want it to go. It goes where I
Correct.
don't want it to go, which is
Correct.
visceral fat. And we
Yes.
do know it is that visceral fat that is metabolically unhealthy, so to speak,
Right.
and creates that increased risk for diabetes, heart disease, et cetera, et cetera. So I always just show my patients this is real, this is why, and you're not imagining it. And then I go over my 4M pillar path or plan, so which is meals, movement, mind, and medicine. If they choose not to utilize medicine, that's okay because we still have the three pillars to kind of
Hmm.
talk about. So in that situation, we start with the science. So what's the science? We lose muscle mass, we increase visceral fat. So right there are 2 points of points of issue that we can address. So losing muscle mass. So if that's the science, we lose muscle mass. How do we change that? Because we
Right.
thought absolutely can change it, right? That's not
Yes.
a destiny.
Right.
That's not set in stone. So from a meals perspective, we just talked about making sure we hit our protein.
Right.
From a movement perspective, love cardio, but let's also give time for strength training because
Yes.
both are equally important.
Right.
And the way I always say it is what do you want to start, right?
Hmm.
I'm on, so we know strength training is definitely helpful, but if somebody comes to me and says, I haven't worked out in a while, but I used to love walking. Hey, let's start walking. Let's start with
Yes.
that. Let's start
Yes.
with what you want, so that becomes your new identity, and then we can layer on the strength. And then the third pillar is mind, and under mind, that I divide that into sleep, stress resilience, and then mindset. So,
Hmm.
and actually, stress resilience and mindset kind of are the same. There's always two things. So we all have stress, right? And I always tell my patients the goal is not to eliminate stress. The goal is to have a way to handle it. And
Yes.
there's two things that's always in our ability is in our power, regardless of the circumstance. And I'm being very respectful. Everybody has their
Right.
own story, their own circumstance. But regardless of any circumstance, there's two things that's always in our power as human beings to help us with stress. The first is the power of breath,
Hmm.
and the second is the power of our words, how we talk to ourselves. And that's kind of
Yes.
what it is. And but yeah, I mean, and again, that would be the three kind of lifestyle pillars I would
Hmm.
kind of
Yeah.
talk about. And same thing, I never push, but I also show like, hey, this is the science on like
Right.
you know, anti-obesity medicines,
Mhm.
GLP-1s. This is a science on hormone therapy, right?
Yes.
So yeah, that's kind of how I would try to approach that.
That makes so much sense. I love the easy way you lay it out for us, right? These are the 4 areas, and this is how we break down each area, knowing that we probably won't hit all 4 at the same time. We'll do one at a time and get it right and then go to the next one.
Absolutely, one at a time.
Yes.
Again, the brain will resist too
Uh-huh.
much.
Yes.
So to me, it's all about, hey, this is the general idea. What's the first step that you can do? And that's what we're going to work on together.
Love that. So, switching to the other side, that 4th area you talked about would be medicine. And we've hinted at this a little bit. The question I find comes up the most, whether it's the GLPs or the hormones, is what happens to me when I stop taking them?
Hmm.
And how do we know that if I take them, I'm not going to be back in the same place I am right now?
Yeah, that's a very common question.
Mhm.
So, how I talk about that is I always start with the science again. So it's to, because I think it helps with understanding why we're even going to do it. I mean,
Right.
obviously in the appropriate patient. So let's just take, you know, Anna A, right?
Mhm.
So if she struggled with her weight her entire life since she was 10 or 11, she's
Mhm.
done all the diets you've imagined, has lost
Yes.
100 pounds and regained 120,
Yes.
right? So that yo-yo effect. So for that person, that has a different physiology than someone who just gained weight, let's say maybe in the last, who just gained 10 pounds in the last, I don't know, 3 years. So
Yes.
that they have different physiologies. But for the first patient, I would explain to her like, "Hey Anna, right? This let me explain to you how let me share with you the information that I know about
Mhm.
weight and how it's regulated by our brain." And then
Mhm.
I go over all of that. And when I explain to them like this is like biology, this is
Mhm.
not lack of willpower. This
Right.
is really like hormones that we not can cannot necessarily control long term,
Mhm.
then they can understand, okay, yeah, so medicines can help regulate that dysregulation.
Mhm.
And one of my favorite analogies is actually glasses. So when we get older, and this is something I
Yes.
even use it for like the second patient, like when we get older, like
Mhm.
we know your eyesight is going to
Yeah.
go back.
Right.
So we can choose to continue reading the phone like this,
Mhm.
which is what I do when I don't wear my glasses,
Yes.
or use a tool in the toolbox to
Right.
help me not be squinting all the time.
Yes.
So that's the tool in the toolbox. And that's what medications are. They're a tool in the
Mhm.
toolbox. They're not a
Yes.
replacement. And it's always all four. If you do the
Mhm.
medicine alone without the three, it's not going to be a long term solution. That's what
Right.
I offer my patients. This is a long term plan. This is not you know, uh, a 3 month, 6 month like
Mhm.
plan. This is something
Right.
that you will use long term to keep the weight off, which is actually the
Yes.
hardest part.
It is.
Yeah.
I think we all know that from lived experience in ourselves or others. But it's sometimes shocking. You talked about the way you talk to yourself, the excuses or the reasons we give ourselves for why we're different than everybody else and have failed on this, even when it's a biology problem. And so I love that you're pulling that out. One of the
I
other
think
things I run,
us doctors are the hardest on ourselves
oh,
too.
100%. Like, I don't need to judge anyone because I'm too busy judging myself, right? Like, I've got all the things I'm failing at. How can I look at
That's
anyone
right.
else's life
Yeah.
and pick it apart? But one of the things that I guess I felt this kind of fell into my lap, it wasn't from med school or residency training, but I was talking to a patient several years ago and I'm listening to her and I was like, this doesn't really fit the classic obesity pattern. It's not really the perimenopause thing. And I honestly don't remember how I found it, figured it out, but there was something that came up called binge eating disorder. And the
Mm.
more I read about it, the more I learned, I was like, oh, wow, this is really underdiagnosed in women. Oh, wow, this doesn't have to just start in childhood and be forever. Oh, wow, this might be something a lot of women need help with. Maybe I need help with, right? And so I think when I bring this up with my patients, I have to be very careful because many people hear the word binge and they immediately associate it with bulimia, like binge purge. And so
Mm.
then I have to separate for them. No, they're two different disorders, and they're both, yes, they both affect your eating, but one of them we can actually do a lot with it, and not necessarily cure, but get pretty close to that with oral medication, such as Vyvanse. And I'm shocked how many times women will tell me I'm just a stress eater, and then I have them take the binge eating disorder validated screening.
Hmm.
And it's like, oh no, you have binge eating disorder. Let's
Hmm.
treat that first and then work on your mindset, work on the habits, and see if we can't get you a place. And most of those women say some iteration of this comment: I didn't know how much food noise I was having. I didn't know it was there until it went away. And I wonder in your practice if you run into that concept at all. I mean, we're looking for it now. And so, of course, if you look for something, you see it pretty
Yes.
regularly, right?
Yeah.
But I'm just wondering, in your experience in these fields, is that something you run into?
So definitely run into the statement of I'm a stress eater a lot.
Hmm.
For that particular patient, it really would be looking at, it's a nuance, right? And this is
Yep.
kind of the fun part and the
Right.
challenging part of it is like
Yes.
a lot of it. So I've definitely had patients that have said that, and
Hmm.
then when we adjust their protein, they don't have it anymore.
Great point.
So, and then
Yes.
I have other patients that have said that.
Yes.
And then when we work on that, so again, that was meals, right? And then when we
Right.
work on the mindset part in terms of like, yeah, this was a dopamine hit. And
Hmm.
we create strategies of, okay, when I'm stressed, and then we kind of talk about safety, and like, I want to say safety, like you're never wrong, kind of really self-empowerment,
Hmm.
and
Hmm.
then creating those strategies around those, then
Yes.
sometimes that doesn't happen. But
Right.
there are definitely truly, I mean, we know it's true, right? It's a diagnosis,
Yes.
where it's uncontrollable. And I've
Right.
definitely had patients that yes, it's kind of like, what's the term? Your heart goes out to them. The true
Yeah. Right.
it's like, oh wow, yeah, it's
Yeah.
affect it's yeah. Anyway, so yes, it's very real. But I before I would kind of deep dive into those kind of
Hmm.
first.
Yeah.
But it's very real, and the medicine definitely
Yeah.
helps. Because again, it's biology. I mean,
Right.
it's a brain dopamine regulated
Yes.
dysfunction, right? Kind of like
Right.
everybody's brain is just different.
It
Like,
is.
how
It
boring would
is.
it be if we all have the same freaking brain? That would not be
Correct.
a fun place.
Correct.
Yeah.
No,
So
not at all.
yeah.
No,
So tying
that's
it
great.
back to biology, I think, is
Hmm.
always helpful, and I'm sure that's,
Yes.
I think that's
Yeah.
how we all do it. You know.
Yeah. No, I think that's well said. So thank you. Let's shift and talk about some tensions you run into. What are some frustrations that we haven't talked about? And it could be with the healthcare system. It could be with your lived experience of trying to provide care where insurance denies care. I'm just making these up. Where are some areas that you would say in your lived experience as a physician, it's really frustrating? There's a tension between what's real and what you have to do or provide and what the patients expect.
Oh,
And
I
how do we
guess.
bridge that?
Yeah. I mean, obviously, the first thing is insurance, right? Like,
Mhm.
I mean, well, that's gonna be like a 2 hour debate.
Yes,
But one, that's
different
a
day.
barrier. We all know that. I mean,
Yes.
everybody and their, everybody who's not living under a rock knows what insurance is, the
Right.
barriers that it can kind of
Yes.
give. I mean, even for menopause treatment,
Mhm.
I have patients that it's not covered. I mean,
Right.
it's like generic.
Right.
So anyway, I mean, thankfully there are. It's not at least the hormone therapy options. They're generic, so it's not
Yes.
like $1,000, right?
Mhm.
I think honestly, the struggle lately that I've kind of been noticing is, mm, when well, and again, I prepare for it. So it's really when patients are being told by other providers
Yes.
that, oh, you're on estrogen, progesterone, and testosterone. That's bad.
Yes. Yes.
So I
You're
know
poisoning
that.
yourself.
What's that?
You're poisoning
Yeah.
yourself.
So I know the other clinicians would say. So I always tell my patients in the first visit
Mhm.
that I'm taking all this time to educate you because
Yes.
I want you to be aware that, number one, this is all based in science. Number two,
Mhm.
nine there will be a lot of clinicians
Right.
that will not understand this. There'll be some that will, and they're okay with
Yes.
it, but majority will like question you. Why are you taking
Right.
that? So that would be the and again, this is because of a recent situation.
Hmm.
Yeah, so that was kind of like, and I'm upset for them basically. I'm not
Right.
upset for myself because
Right.
I know I'm standing on science, and I know
Yes.
anything that is hurled at me, I could give them a
Yes.
journal. I can give them, and not just random journals, but
Right.
American Heart Association,
Right.
American
High
College of
quality.
Orthopaedics. Yeah. So, but I'm just kind of like feeling for the patient, right? So
Yes.
because they're like, well, mine, well, I should say, like, I don't think my own patients experience this in the sense of like, they don't know who to trust. They do know because I
Hmm.
spend time to talk to them, but
Right.
I've definitely seen some, you know, acquaintances that kind of like curbside me and say my
Yes.
doctor said this, and I just like, that's not true. Like,
Right.
that's not
Right.
true. Like,
Right.
so I feel for those that are being told incorrect things.
Hmm.
And even
Right.
for weight, honestly,
Yes.
it's like, oh, that shot is horrible. I mean, like, it's
Hmm.
not, it's
Right.
like, so yeah. So, well, I think the weight and midlife, right, is such a huge intersect, in
Totally.
terms of like what it's going through.
Yes. Yeah. I find it frustrating in those same kind of situations you're describing where there's obviously a disconnect and neither side necessarily has the time, the energy, the space to pick up the phone and say, what are you doing? Like, why are you doing this? Teach me, right? And neither did I when I had 3,000 patients. I would
Oh,
never bother,
no,
right? You
no.
couldn't because you were surviving. But now it's almost it's startling and funny when it happens because I'm like, oh yeah, I have to put myself back in their shoes. I
Mhm.
didn't know it either, and I had to learn it. So in this one little tiny area, I'm just a little bit further on the path than they are, right? And so how can I respectfully give them information without making the patient feel like one of us doesn't know what we're doing? Because that destroys trust for
Yeah.
both relationships. And I haven't figured out the perfect way to do that. So when you figure that out, please teach me, okay?
Yeah.
But
Yeah. I
what?
mean, I don't know how to broach.
Mm-mm.
So let me tell you an interesting story. So, I don't know how to say it. Basically, somebody I know who knew what I was doing, who knew I have
Mhm.
my practice that
Yep.
is exactly this, like literally told me like, oh, the estrogen will give you breast cancer. I'm like, no, it won't. And this
Right.
was somebody I was seeing, right? Like, so
Yes.
I was like, professionally, and then I said no, and then they said it again, and
Mhm.
I'm like, we can just respectfully disagree.
Right. Yes.
So, and I was sharing that with some other colleagues, and it's like, if that's what's being told to me,
Correct. Correct.
right, like how can somebody else kind
Right.
of get the right information? So, and
Correct.
again, I know it, and we just shared it, 30
Yes.
patients a day.
Right.
How do you rewrite the story?
Right.
I don't know. I mean,
So my latest iteration of exploring this tension is to write a personal letter that actually goes in the mail and just say, thank you so much for the care you're providing. This is why I'm saying this. I would love to talk to you about it. I know you probably don't have time. If you want to look at some articles, here they are. And letting it go from there. But I almost feel like that's aggressive. Like if I got that message from somebody,
I
like, who
know.
are you? What are you doing? Right. So I haven't actually sent it yet. It's kind of sitting in my queue of things, projects, if you will. But I think there has to be a way we can communicate with each other. And it doesn't help that there's different people with different certifications coming at it from different ways, and that the patients see that, they see TikTok, they see it all, right? So there's a lot of opportunity to improve trust and clarity, but I haven't figured out the easiest way to do it.
I don't know either, and I think sometimes I just kind of like reframe it and like, I can do what I can with
Hmm.
what I can, and that
Yes.
starts with my patients,
Yes.
right? So I will educate them. I will give them the journal articles.
Yes.
I will tell them like, you're not good. You're Some people will say like you're crazy. Some people, some people will not like that you're on it, but know
Hmm.
that you're standing this. We're doing
Yeah.
this in a way that's
So,
safe for you,
right.
and then I do it there. So yeah, right. We can't change the world. I
No.
mean,
No. Well
we will
put.
go we will
We'll
go
go crazy.
crazy.
Yeah, exactly. So, one other thing I'd like to explore before I let you escape today. I would say here in St. Louis, definitely the last 5 years, maybe a little longer, a lot of our gyms have these in body scanners.
Mhm.
And in any clinic I worked with, for residency, as faculty, all that, that was just never there. So recently I bought not an InBody, a different medical grade body composition
Mhm.
scanner for our office. And I think my staff thought I was a little bit nuts for doing it, but I thought we've got to give people what they're looking for, that in a clear result. And
Yes.
so how do we do this? So for me, it was buying this machine, and now I go over it with our patients. But what I think is interesting is there's a lot of areas, and that's just one example, where the non-medical world comes up
Mhm.
with something that's actually really good. But the clinical world is like, no, no, we don't have that. We don't need it. It's not right. And that tension also causes distrust. And I wonder if you want to comment on that, or you have an example of your own. How can we start to bridge that better?
Um, I guess I'm a little unclear on the question there.
Yeah. So
So
for
in I
me,
think in bodies are or muscle mass
mhm,
composition
right.
are a great
Yeah.
tool. So definitely something that I think is useful. Yeah.
Yeah. So I guess the question, sorry, I word it badly. I always think I'm a good communicator, and then I
No, you
realize
were.
that
I
I'm
just
not so
like,
good. So don't worry. My
I
husband,
think
my
there's
staff,
two
and my
thoughts in
kids
there.
remind me every day.
I
Yeah.
couldn't
No,
intervene.
it's okay. So I think what for me, the reason I bought it for our practice is I wanted people to be able to know that we see what they see, we hear what they're hearing, we're trying to address the concerns, and we're going to do it in a safe way. And I wasn't trying to necessarily bash InBody. That's not where I meant to do with that. But it was this idea of how can we have all the gyms with this information, but the medical system's not using it. There seems to be a disconnect to me.
Oh, you mean the like regular primary care doesn't have like
Right,
this
exactly.
tool.
Someone who
Gotcha. I
hasn't
see what you're saying.
intentionally done it
Yes.
for their like, it's
Yeah.
such easy information. It's good
Yeah.
information. So why aren't we like, I guess I don't understand why that isn't part of medical education, why that isn't being, why are physicians not said, well, we don't have it here, but go down to the local gym and get one, right? I mean, that's
Yeah.
not easy,
Yeah.
but that just seems like such a disconnect. And
Yeah.
people want that information. It is helpful
100%.
information.
Sure. Yeah. Yeah. It 100% is helpful. Um, I mean, so before I opened my own practice, I was in a obesity medicine practice. So that
Mhm.
was just all we did was we saw patients from primary care specifically just with weight. And in our
Mhm.
practice, we did have a body a BIA, body
Yep.
impedance analysis
Uh-huh.
scale. So, I would hazard a guess that it all comes back to money.
Yeah.
Maybe like for
Right.
them, like maybe the offices don't have or time. I mean, we just
Right.
talked about how they probably have 5 to 10 minutes to discuss chronic medical conditions, and then
Yes.
oh, by the way, again, right?
Right.
So throwing
Right.
that in there, but I definitely think it should be part of the conversation.
Mhm.
100%. It
Mhm.
and you're absolutely right. People want that. People want
Right.
metrics
Yes.
that they
Yes.
can utilize and understand. And
Mhm.
yeah,
And it's obviously easy. There's no risk of harm with it, unless
no,
perhaps psychological, right? Like some people may not want to see it, but compared to everything else we do in medicine, it's such a low risk thing.
correct.
Just like,
Yes,
why are we not doing this? So it's just interesting to me. I was curious what you run into. And I suspect we'll see more over time, but I could obviously keep us going for a long time. Super interesting, different topics. So thank you for being willing to come on the show and talk to
absolutely.
us about that. Um, tell us, if a listener wants to connect with you, how would they do that?
Yes. Well, for again, thanks for having me. This has been
Yeah,
such, I mean, 46 minutes already. Can
I
you
know,
imagine
right?
this? Time flies when you're having fun.
It
So again,
does.
I am licensed in the state of Pennsylvania. My website is www.midliferemedy, REMDY. I am on Facebook, YouTube, Instagram, TikTok with that same kind of handle. And if you are in the state of Pennsylvania, I would love to help you lose weight, balance your hormones, and just feel like yourself again.
Yeah, which is what we want. We want to all feel our strongest,
Mhm.
best self. Love that. So that is amazing. Thank you for being here and being willing to share with us. I know that we're going to be able to connect again in the future and continue these
Yes.
conversations, but it has been a real pleasure to have you. So many, many thanks.
Yes. Thank you.